You're listening to Weird Medicine with Dr. Steve on the Riotcast Network, riotcast.com.
I've got diphtheria crushing my esophagus. I've got Ebola virus dripping from my nose. I've got the leprosy of the heart valve, exacerbating my incredible woes. I want to take my brain out and blast it with the wave, an ultrasonic, echographic, and a pulsating shave. I want a magic pill for all my ailments, the health equivalent of Citizen Kane. And if I don't get it now in a tablet, I think I'm doomed and I'll have to go insane. I want a requiem for my disease, so I'm paging Dr. Steve. Dr. Steve!
It's Weird Medicine, the first and still only uncensored medical show in the history of broadcast radio, now a podcast. I'm Dr. Steve with my little pal, Lady Diagnosis, she who will do most anything for a glass of expensive wine. Hello, Lady Diagnosis.
Hello, Dr. Steve.
And we have, again, the man who would know more than anyone what she will do for a glass of expensive wine. It is Dr. X, everyone. Hello, Dr. X.
Hey, Steve.
This is Lady Diagnosis' boyfriend. I guess that's what you are. This is
Paramore.
Or Paramore. This is a show for people who would never listen to a medical show on the radio or the internet. If you have a question you're embarrassed to take to your regular medical provider, if you can't find an answer anywhere else, give us a call at 347-766-4323. That's 347
Head.
If you're listening to us live, the number is 754-227-3647. That's 754. Take it away, Dr. X.
Hey,
22 penis.
102 penis.
Or 754 Bear
Nip.
Follow us on Twitter at Weird Medicine, Lady Diagnosis, or Dr. Scott WM. Visit our website at weirdmedicine.com for podcast, medical news, and stuff you can buy, or go to our merchandise store at cafepress.com/weirdmedicine. Most importantly, we are not your medical providers. Take everything you hear with a grain of salt. Don't act on anything you hear on this show without talking it over with your doctor, nurse practitioner, physician assistant, pharmacist, chiropractor, acupuncturist, anesthesiologist, yoga master, physical therapist, barista, or whatever.
Veterinarian?
Oh, dang you. You always... I stole your joke, and then you just added another one on top of it. In comedy, that's called tagging, Lady Diagnosis.
Oh, did you just tag me, Dr.
No,
Steve?
you just tagged me.
Oh, I tagged you. Yay.
All right. Hey, don't forget to go to stuff.drsteve.com. We had a very interesting new product that we reviewed last time that looks really interesting. I still haven't received mine because we're recording this on the same day, but I'm hoping it will come next week, and I'll be able to talk to you about it. Also, tweakedaudio.com, offer code FLUID for 33% off, the best earbuds for the price on the market, and the best customer service anywhere. And they are a Tennessee.
They really are great.
They're a Tennessee company. We've got to go see them. They're in Franklin.
I know. Let's go.
Okay.
All
we'll
right.
do a Weird Medicine road trip. Are you in, Dr. X?
Absolutely.
Okay, we have to go to Nashville. That's where Franklin is, right?
It's where Vanderbilt is, by the way.
Yeah. Okay. Yeah, very good.
Vanderbilt. Is that a restaurant?
No, Lady Di. It's the true black and gold, not that place in Iowa.
Oh, the Hawkeyes.
Here we go. I don't give a shit. Simplyherbals.net is Dr. Scott's herbal website.
Herbals.
And he has, this stuff. You know,
The nose spray. Oh.
Dr. X, I'm going to tell you something. That my partner on the radio is kind of a nut, but he has this herbal sinus rinse, and really what it is it's buffered saline, but he put peppermint oil in it, and it is fantastic. It got me off of Afrin and Flonase and all kinds of stuff, so I'm very impressed with it. Peppermint oil itself does have some anti-inflammatory properties, so it's really good stuff. So you can get that at simplyherbals.net, and it's cheap too. It's not like he could charge $10 for that, and I don't think he charges anything close to that.
No, I had another guy text me the other day saying how great he loves that stuff.
Yeah,
best ever. He said.
Well, and GVAC loved
he
his
said fucking amazing.
GVAC loved his fatigue reprieve.
Yeah,
and my wife likes the stress less. So it's that's all very anecdotal. I would love to do a double-blind placebo-controlled study on some of Dr. Scott's stuff just to see what's there.
Right.
We obviously in Western medicine don't know everything.
He's got something.
Always learning new things, but the problem with things like these herbal supplements is they don't have to do any studies. They could just put them out, and then they finagle it by saying, well, this is not intended to treat or diagnose any specific disease, but then it'll say kidney health on it or whatever. So, I am confident that Dr. Scott would have some positive results with his stuff. Mm-hmm. And one of the things that we talk to our listeners about is just how do you know things? How would you know if his stress less? Like people say, well, is it any good? Well, good for what? What do you want to accomplish? Mm-hmm. Do you want to be less fatigued? Well, we could do a study for that because there are validated fatigue scores. I
was going to say, can you measure it?
Yeah, there are these validated tools that are the best that we can't do a blood test for fatigue, mm-hmm. but it's a subjective complaint anyway. So there are instruments that are basically surveys that have been studied and validated and shown to be consistent from one group to another that you could use. So now that's going to be the tool we're going to use. Mm-hmm. And our endpoint, we have to choose an endpoint, right? So our endpoint is going to be, we want to see a statistically significant improvement in those fatigue scores. It could just be health-related quality of life. That could be something else that we could study. There's instruments for studying that. So we'll say, well, maybe we won't get anything on the fatigue, but maybe we'll get something on the health-related quality of life. And then you give 100 people or whatever, you pick an arbitrary number, but it needs to be large enough so if there's a negative result, it's got enough power to be statistical. So let's say we get 100 people. We give 100 people fatigue reprieve, fatigue reprieve, and another 100 people we give them a placebo that looks and smells and tastes just like it. And we don't know which one is which. They're coded with a code, and that's in a book somewhere that somebody else did. And so we have no idea what we're giving the patient is a placebo or it's active study drug. Mm-hmm. And the patients don't know because if the patients know, they may be biased one way or the other. Like if they don't believe in herbal stuff, they're going to be biased against it, say, oh, hell no, that stuff didn't do anything, even though maybe they would have had an effect if they had been honest about it.
Right.
I remember I was in a double-blind placebo-controlled acne study when I was in college, and I went in to get tested, and they do this comedone count where they count the number of basically zits and pre-zits and post-zits on your face in a certain part of your face. And I said, I don't think this stuff's doing anything. I must be getting the placebo. And the woman said, oh, well, let me check. And she goes, oh, no, you're getting active drug. It's like, you just screwed the whole study.
It.
She ruined the whole study by
God.
doing that. Okay, she should not have had. No one in the study should have had access.
That should have been hermetically sealed in a mayonnaise jar.
That's right. That's exactly right.
With some semen. Oh, sorry.
That was last show. Wrong show. But so anyway, so no one can know, and that way they can't have a bias. And then at the end, you give them those whatever these instruments are: health-related quality of life, fatigue scale. Mm-hmm. And you have them do a survey. And then once you get all those stacks of paper, now you can decode it and say, well, this one was placebo, this one was active drug. And you see if there's a statistically significant difference in any of it. It could be post-exercise fatigue. There is a benefit, but not early morning fatigue, mm-hmm. things like that. I mean, those things can dope that out. And you could say a statistically significant difference. And now, once you've done that, it needs to be repeated somewhere. So you publish your study and let somebody else repeat it to show that it's reproducible. And if it's reproducible and statistically significant, then you can make a blanket statement that this stuff has some demonstrated efficacy for whatever it is. But, choosing your endpoint's the big thing. If you choose your endpoint, for Viagra, when they were studying it, not a very good blood pressure medicine. Their initial endpoint wasn't erections, it was blood pressure. And it was terrible. And they were, maybe even thinking of just trashing this drug and moving on to something else, except that people were like, dang, all of a sudden my erect penis looks like a Nathan's Frankfurter in the microwave. And And that's not my joke, by the way, but I use it every time because it's so great. It's so descriptive of what a Viagra penis looks like. Ooh. And so then they changed their endpoint and studied Viagra. So the active ingredient is sildenafil for erections. And when you change your endpoint, all of a sudden you might show something different. So, Dr. Scott's thing could be the cure for cancer, and we would never know it if we didn't study for it, study it for that.
So,
yeah, go ahead.
So what, like there's the CDC for drugs and FDA for food. Does somebody monitor?
They do,
this stuff?
and Scott could tell
horrible?
you there is the FDA still monitors this stuff. For example, every once in a while you'll see an herbal medication for erectile dysfunction get pulled from the shelves. And the reason it got pulled from the shelves is because it had sildenafil in it, which is the only way you can get that in the United States is with a prescription. Well, they were doing some herbal stuff, and then they crushed up some Viagra and stuck it in there so that, to improve the efficacy. So people go, yeah, this stuff really works.
Right.
Well, the FDA will pull these things from the shelves and test them looking for things like that. And
but to put that label on saying stress less, they don't say no. You have to prove it.
No,
so you can
because it's a nutritional supplement, but they have to be careful about the claims they make.
Right.
And I have seen things getting pulled because their claims were too specific.
Okay.
So there you go. That's why Dr. Scott calls it stress less. Right. It doesn't say cures fatigue.
Yeah. Energy.
Or
pills.
Right. Or decreases. Well, he doesn't make any claims at all.
Right.
But anyway. All right. Very good. Let me see if we've got... Oh, so I had this thing. I want to read this story to you, and if I can get back to it. This is from CNN Politics, and it says, David Pecker, the head of the company that publishes the National Enquirer, was granted immunity in the federal investigation into President Donald Trump's former attorney Michael Cohen in exchange for providing information on hush money deals, according to the Wall Street Journal. Pecker, the CEO of American Media Incorporated, told federal prosecutors that Trump had knowledge of Cohen's payments, whatever, blah, blah, blah. So I have this picture of a screenshot from CNN.
Did you say Pecker is the head of media or meaty?
Yeah, he's the meaty head of media. So this is actually from MSNBC, and it is that woman that says sort of all the time, and I can't think of her name, but it says, Trump worried about Pecker leaking. It's just too great. Wait.
Real life.
Yep. So I don't even know if that's a Photoshop or not, but I could actually absolutely see them saying that. There's just too many jokes.
Pecker
just write
leaking.
your own joke. I don't have to make a damn joke about this guy's name. It's like, why don't you just have your name be Cock? I always wanted to have a liquor store and call it Cox Liquors. Mm-hmm. They couldn't say anything. Just COX, like it's a family name.
Right.
Cox Liquors.
Liquor.
That was the head of the urology department where I trained.
Oh, is that right?
Dr. Cox.
Is that right?
Absolutely.
We have a
really?
dermatologist named Rash.
And there was the retina surgeon named Dr. Blinder.
That's
Ooh,
awesome.
Yes.
That's cool.
My doctor when I was a kid was Dr. Cocaine. It was spelled COCANNE, but it was pronounced cocaine. So, go. All right. Let's see. You want to take some medical questions?
Sure.
Number one thing, don't take advice from some asshole on the radio.
All right.
Hi, Dr. Steve. I'm calling from South Dakota. I am type 1 diabetic, and I've got gastroparesis. And I was hoping that between yourself and Dr. Scott, maybe you could fill me in on what I can do to lessen the effects of that and hopefully make myself more comfortable instead of being bloated all the time.
Yeah. Okay.
What did he say he had?
So he has gastroparesis, which means that his stomach is basically paralyzed. And, diabetes causes a lot of nerve problems. People hear of diabetic neuropathy. where people will lose the feeling, or they'll get burning and stinging, or a heat feeling, or electrical discharge kind of in their fingers and feet and stuff. I've seen people before in the burn unit that had diabetic neuropathy so bad that they felt cold all the time and stuck their foot in or feet in the oven to warm them up, and then end up in the burn unit because they fell asleep and they burned their feet up. So it's a really bad disease, and when it affects the nerves of the stomach, of course, it paralyzes the stomach. Stomach needs impulses from the nervous system to massage food and mix it up and then get it to pump out to the intestine. And when it doesn't do that, you just feel bloated, and you can have reflux and puke and stuff like that. So you got any experience with this? Because we could talk about the medication, but then now there's a surgical procedure for this.
Yeah, my experience is pretty limited from back when I was a student and a resident when they were doing double-blind placebo studies on some new drugs that got pulled. Yeah. It's a horrible disease.
What was the name of that one? It was I can't. It's right on the tip of my tongue. It was a great drug too. Prokinetic. Let me look it up. Drug removed. Let's see if it comes up. Cisapride. That was it. Cisapride.
That's what I was going to say.
Okay, so cisapride was one that worked really well, but there were some adverse effects, and it got removed from the market. It worked on serotonin receptors in the stomach, and it was primarily used to improve muscle tone in the lower esophageal sphincter, which is, our listeners know what that is, the little ring of muscle between the esophagus and the stomach, where that tries to prevent reflux. In other words, food getting from the stomach back up into the esophagus. And people were getting irregular heartbeats from it, and it was removed from the market. So there's some other medications. There's one called uricoline, bethanechol, and we would use that sometimes for people that had post-delivery ileus, which is a paralysis of the bowel, where it just sits there and it's flaccid. It doesn't contract like it's supposed to, so people blow it up and they don't have bowel movements. It's supposed to help the stomach empty faster. And then there's the classic one that we all use is metoclopramide. Metoclopramide is a drug that helps improve peristaltic function in the GI tract all the way through. So, but I'm assuming if you're calling, you've tried all of these things, and if you have and that doesn't work, then it's still a real problem. So there is this thing called a gastric pacemaker. You guys ever put one of those in?
I've had patients that have had them in, but I don't think anyone in our area is implanting them. Okay.
So what this does is it's an electrical stimulator, like a pacemaker for the heart. And remember, signals from the nervous system are basically electrical signals, right? And if you put a pacemaker on the stomach, you can actually stimulate it to now contract, whereas before it wouldn't contract. And I don't know how these things work, if they're programmed to only start contracting after the stomach is distended or any of that. So I know nothing about it. So maybe somebody that knows something about it can call in. That would be the way I would design one, with a stretch receptor on it. So when food goes into the stomach, it starts to stimulate gently in one direction from the body of the stomach to the antrum.
I think there's a way they can activate it once they've eaten or start to eat.
Oh, is that what it is?
Yeah. Some of them will have some pacemakers you can put a magnet on them and that gives it a signal. I'm not sure how they do that.
Well, so I'm looking at this article here. It says the electrical stimulation involves attaching two insulated wires to the lower body or the antrum of the stomach. The electrodes attach to the neurostimulator that is placed in a subcutaneous pouch on the abdominal wall. So like a pacemaker, they insert this little pouch under the skin, and you've got this little place there. It says it can be programmed to enhance the frequency of gastric contractions, and the mild electrical stimulation of the antrum portion of the stomach muscle wall helps to reduce nausea and vomiting. Wow. Well, that's pretty damn cool. So that's what I would go for if I had this and everything else had failed. So talk to your gastroenterologist or your gastric surgeon about consideration of gastric electrical stimulation if everything else has failed. You got anything else to add to that?
No, sir.
Okay. All right.
Today's episode is brought to you by Angie. Angie has made it easier than ever to connect with skilled professionals to get all your jobs and projects done well. Let me tell you, there's the version of it where you try to do something at home, and then there's a version of it where you have someone help you, you watch them do it the right way, and you go, thank God I didn't try to do that myself. I have fully done things around the home that I think look good, and then a bang in the night, and I wake up to a shelf collapsing, a painting falling off the wall. I've seen it all go south. I own a home, and I can tell you, I know how much work it can take. Whether it's everyday maintenance and repairs or making dream projects a reality, it can be hard just to know where to start. But now all you need to do is Angie that and find a skilled local pro who will deliver the quality and expertise you need. Whatever your home project, big or small, indoor or outdoor, you can Angie that and connect with skilled professionals to get the project done well. Right now, one of my wish lists is I want a bike for my condo in Milwaukee, and I would love to rig it up on a pulley in the ceiling because I have one of those like lofted ceilings, but I'm so scared to try that on my own. Angie has 20 years of home experience, and they've combined it with new tools to simplify the whole process. Bring them your project online or with the Angie app. Answer a few questions and Angie can handle the rest from start to finish, or help you compare quotes from multiple pros and connect instantly, which means you can take care of any home project in just a few taps. Because when it comes to getting the most out of your home, you can do this when you Angie that. Download the free Angie mobile app today or visit Angie.com. That's ANGI.com.
Hey, Dr. Steve. It's Brian from New Hampshire.
Hey, man.
I got facet joint arthritis, and my doctor left, and my new doctor automatically, first thing he says, he wants to take some of my pain meds away, and I barely get enough to work or anything. And I'm on 50 microgram an hour fentanyl and 3 perk 5s a day. My other doctor said I was just under what the government was requesting, whatever the word is. And the new doctor says I'm over it.
Oh, I know
I
what's
don't know
going
how to
on.
do that math or what it equals to on. I have no memory anymore.
Well, that's okay. I can help you with that. So he's on transdermal fentanyl, 50 micrograms an hour patch. And that's equivalent, and this is the equivalence we use, and I would be interested in hearing your thoughts on this, that 1 microgram an hour is equivalent to 2 milligrams per day of morphine. So if he's on a 50 microgram patch, that would be equivalent to 100 milligrams of oral morphine or 10 Lortab 10s. When we talk to lay people, we always convert to Lortab 10 equivalents because that always makes sense. If I say you're on 875 oral morphine equivalents, nobody knows what the hell I'm talking about. But if I say you're on 87 and a half Lortab 10s, they go, oh God, that's something they can relate to.
Yeah, we use morphine equivalents in anesthesia.
Sure.
So
yep.
That's our.
Would you agree that 25 or 50 mics per hour would be roughly equivalent to 100 milligrams of morphine a day? Is that about what the conversion that you use? Okay. So that's 100, and then he's on 5 milligrams of oxycodone 3 times a day. That's what those perk 5s are. That's the active drug is oxycodone and acetaminophen. We'll forget about the Tylenol and concentrate on the oxycodone. So 5 milligrams of oxycodone is equivalent to 7.5 milligrams of morphine. So let's figure. I can't do that in my head. Alexa, what's 7.5 times 3? I'm just
23.
Thank you. It's 22.5, right?
Yeah.
Uh-oh.
She 7.5
multiplied by 322.5 equals 2,418.7.
No. Alexa, stop. It's 22.5, right? We don't have to ask her that. Okay. So 22.5 plus 100 is 122.5 oral morphine equivalent.
7.5 multiplied by
Alexa,
320.
Stop. All right. So she's hilarious. So most states have a threshold of 120 milligrams. If they have guidelines at all, they're going to have a threshold of 120 milligrams of oral morphine equivalents for doing things like referring somebody to a board-certified pain specialist. And there are other things that you have to do, like in Tennessee, if you're on 120 oral morphine equivalents and you're on a benzodiazepine, which is the tranquilizers like Valium, Xanax, and Ativan. Well, I don't want to drink after you. You're gross. I don't know what's been in your mouth today. So
you don't want to know.
Dr. X raises his hand. That's a good move on the radio.
Yeah.
Anyway, so if they're on benzodiazepines, they also have to be referred to mental health specialist if they're on greater than 120 oral morphine equivalents. So he's right on the borderline of that. Well, he's actually technically over it. So that's what his doctor is telling him. The CDC has its own guidelines, and they say go easy over 90 milligrams. And so we've got a lot of doctors, but they don't say don't write 90 milligrams more. They just say that should be your target. But if you have to go over that, just document why you had to go over that. A lot of doctors have taken that as to be a hard stop. And 90 morphine equivalents is not a whole lot for people that are on long-acting and short-acting. In other words, people who have chronic, non-malignant pain that requires round-the-clock dosing. Those people will often be on things like he's on, 120 milligram of oral morphine equivalents or more. And so they all run afoul of the CDC guidelines if their doctor all of a sudden says, well, I'm not going to write more than 90. But particularly cancer patients many of them need much more than that. I've got people on, I think the most I've ever had was 7,000 oral morphine equivalents a day. This was a person that had such horrible, horrible pain. And I can tell this isn't a HIPAA violation because it's not identifiable. And it's for educational purposes. Let's just say it doesn't matter why they had their pain, but it was so horrible that somebody else had put them on a dilaudid hydromorphone PCA pump at 14 milligrams an hour.
And they were breathing?
Yeah, they were totally, because they hadn't got there overnight. They'd gotten there, it started at 0.4 milligrams an hour, and then went to 1 milligram, then 2, then 4, and then 8, and so 14 milligrams an hour. Let's let Alexa help us with this. Alexa, what's 14 times 24?
14 multiplied by 24 equals 336.
So that's 336 milligrams of IV Dilaudid per day. So I just said the number. What'd she say, 324?
Mm-hmm.
Is that what she said? Alexa, what's 324 times 30?
324 multiplied by 30 equals 9,720.
Alexa, what's 9,720 divided by 1.5?
9,720 divided by 1.5 equals 6,480.
Okay, so it's 6,480 milligrams of oral morphine a day, or 640 something Lortab 10s a day. And I think that's my record. And so that's very, very unusual. Patients like that, we can convert them to methadone, and methadone is so potent that you can get them down to like 30 milligrams 3 times a day sometimes. But we would do that first line for people. Methadone's a wonderful drug for pain. But it carries the black box warning that it can cause a thing called prolonged QT syndrome, which is just, don't worry about what that is if you're listening to this, but it's a change on the electrocardiogram, but it predisposes you to an arrhythmia called torsade de pointes, which is, it can be a pulseless rhythm sometimes and can cause fatality. So I did some research on that and found of 5 million people that were treated with methadone at high doses, only 5 had torsade de pointes. And not all of those died from it. So it was 1 in a million. Those are pretty good odds. If I gave you those odds, you'd go to Vegas and bet everything on red, But anyway, so that's the issue. So this guy is either going to have to find somebody that's more comfortable writing pain medication. That would be a board-certified pain management specialist. And but that's harder and harder to do these days because people are terrified to write opioids, And when I say people, I mean healthcare providers who are writing legal prescriptions for them. The dealers on the street have no problem, have no problem with it. And one thing, Dr. X, and you may be aware of this, since 2010, the number of prescriptions for pain medication in this country has fallen precipitously. And if you go to drsteve.com, scroll down and look for an article called An Interesting Take on the Opioid Crisis, you can see the number of scripts declining very fast, almost as fast as they went up for the years preceding that. But the rate of opioid overdose is increasing geometrically. And I'm talking about deaths from opioid overdose. So you may say, well, how in the hell is that possible? And I'm sure you've got some ideas why that would be. Let me just throw that out and see how smart you are.
Not very, but a lot of it they're getting street drugs. They're getting stuff in from China.
Give yourself a bill.
Of course, that's what it is. And those little white packets with Chinese fentanyl in them don't have the microgram amounts on them. And, something might get stepped on, a.k.a., cut with an inert ingredient, could get stepped on twice or it might get stepped on 5 times. And the one that's been stepped on 5 times is going to be less potent. And if you're used to that, and then your supplier gets something that's been adulterated less than that, you're just shooting up the same amount of powder, but it could be 5 times more potent.
Yeah.
And fentanyl's scary because it's dosed in microgram amounts.
Yeah. I tell people all the time in my practice, that they'll be afraid of overdosing them on drugs. And so
Sure.
Overdose drugs are not inherently dangerous. They're not going to kill you. They just make you stop breathing. As long as I'm around to breathe for you,
right,
you're going to be fine.
Right.
All those heroin addicts back in the 60s would not have died had they had someone to breathe for them.
That's right.
The medicine would have gone away and they'd have been fine. But and that's where the home naloxone, which you mentioned,
Give yourself a bill.
I was hoping you'd bring that up. Yeah,
comes into play. Of course, I often wonder who's going to administer it.
Well, it's usually going to be their buddy that they're shooting up with.
Yeah.
But a lot of times they'll know that something's
if they're
going
still
on.
Conscious.
Yeah, if they're still conscious. Yeah, if they're both unconscious, then that's a problem. But so what Dr. X is talking about is home naloxone therapy. A lot of like CVS in some areas will just give it to you. You don't even have to have a prescription. It's not a controlled substance, and it will successfully reverse narcotic overdose pretty much 100% of the time. But it's short-lived. So what you want to do is have this in your house, and then you can go to I think it's Narcan.com. Is it? Or getnarcan.com. Let me see. Let me look it up because I want everybody who's listening to this to go to this and learn about this because you need to learn CPR. Okay, let me see. This is getnarcan.com isn't it? Let's see if it's getnaloxone. Getnaloxonenow.com.org. Okay, here we go. Okay, now I got it. It is go to www.getnaloxone. That's NALOXONE now.org. And just read this. It's just like learning CPR. You're seeing someone that's having an overdose and you're going to save their life. But when they so you give the stuff and then you call 911 immediately because if they've really overdosed, I've seen this before where someone has so much in their system that you give the Narcan and they wake up and they're fine and then they go right back under again. And I've seen patients that required a Narcan drip before, where we had to set up a constant infusion of Narcan to keep them alive while this stuff got out of their system. So you give it and you call 911 and you save somebody's life. Just the same way you learn how to do CPR on somebody, you can save their life.
So is it a needle you shoot it? How do you do it?
Okay, it's an
Because
excellent
they're passed
question.
out, right?
It's a nasal spray.
There's a nasal spray.
Oh, okay.
And if your insurance won't cover it or if it's too expensive, they can give you pre-filled syringes of Narcan that you can just, shoot them up with it. You just pop it under the skin.
Oh, okay.
I've also seen where they have syringes of Narcan and they give you a little nasal speculum and you stick that in there and just shoot it in their nose that way.
Well, like Pulp Fiction when they...
That was such bullshit.
So that's all I can think of. So that's not real?
No.
It's on TV.
No, taking a giant needle full of adrenaline and then as hard as you can, jamming it into somebody's chest wall and injecting it directly into their heart is not a way to treat a heroin overdose. Now, a cardiac arrest, we have done that in the past. I got you run codes all the time. When's the last time you did an intracardiac, injection, or, you might have done a pericardial?
Decades ago.
Yeah, so we just really don't do it anymore. There's no need for it. It's never been shown to be better than doing it the good old-fashioned way.
Plus, we usually have IV access, so
right. Yeah,
and you got to know where you're sticking.
Oh yeah,
you can't just stick it anywhere.
You got John
in the chest.
Travolta. He's just he's going. Boom. I mean, it was just like it was even harder than a pericardial thump. I mean, they were just jamming this needle.
Now that I've done recently.
Yeah, I have. Have you?
Yes.
When I was an intern, we were doing pericardial thump while we were waiting for the pacemaker to get there, and you could thump this person in there, and you would see this electrical discharge, and you would get a pulse with it.
Yeah.
And as long as we were doing that, they were okay until they could get the external pacemaker on this person. It's crazy.
So you're beating the life into somebody.
Well, and
just pounding them.
The amount of force that you use is really just how much gravity would pull your hand down.
Oh, okay.
But just that percussion on the chest wall is enough in some people to stimulate electrical activity in the heart. That's cool. Have you ever done a diving reflex? You're probably not old enough to have done that.
I'm not that old.
Yeah, see, I'm quite a bit older than you are. When I was in training, we had a case where somebody had a paroxysmal atrial flutter. And this was before the days, or did he have an SVT? I can't remember. But it was before the days of adenosine and stuff like that. So we just decided we were going to do a diving reflex on this guy. We were interns, and you were running the show. So
what's that?
Well, I'm going to tell you. So what we did was we took a bucket of ice water and we shoved his head in it.
Oh, my God.
And within 30 seconds, his arrhythmia completely resolved, and he was back in a sinus rhythm again. We were like, damn. But apparently all mammals have a diving reflex, and that's how whales and other dolphins and stuff, mammals that live in the ocean, can survive. Is when they dive, their metabolism starts to decrease, their heart rate slows down, and they can stay down there for all of these. It's not just great lungs and great circulatory systems. And they're all derived from land animals, and so for some dang reason, all mammals have this. And we never use it, but I used it that day. It was interesting.
That's crazy.
The old diving reef. We used to do some damn shit. I remember.
How do you coat?
I remember one of my senior
charge.
residents.
You didn't.
No, we didn't charge.
It's
for
$2 for a bucket of ice.
Right, and $5,000 for knowing what to do with it.
Exactly.
I remember my senior resident at Chapel Hill getting a C-arm X-ray machine, and he got a big syringe full of dye, and he was injecting into this person's how was he doing this? Okay. No, I remember what it was. This person had a subclavicular central line, right? And so he was injecting dye in and then going, shoot, and then having the X-ray person take a shot. And what he was trying to do was get a pulmonary angiogram. And he was doing it up in the ICU just because he thought he could do that.
Didn't work too well, did it?
No, it didn't work very well. And I'm pretty sure this was the beginning of the end of residents just getting to do stuff that they wanted to do. Back then, we used to plate our own urine cultures, and we would read them, and then we would report it into the chart. It never went to the lab, and then we would treat based on that. And I remember the first time it happened in 1986 when I was an intern in the emergency room, and I wanted to do a wet prep of my own. And they said, no, you have to send that to the lab now. And so I sent it to the lab, and it came back normal. And I called up the lab, and I said, if you saw clue cells, I'm just asking, if you saw them, would you report it? And clue cells are an indicator of bacterial vaginosis. They're just white blood cells no, not white blood cells. They're just regular vaginal cells that have bacteria all over them. Yeah, and you can see them. And I said, if you saw clue cells, would you report it? And they said, oh, yeah, we would. And then 2 minutes later, we get an amended report that says 3+ clue cells. I was so fucking pissed because it was like, if I had done it myself, I would have seen it, and I would have gone ahead and treated this person already. But instead, I had to send it to somebody who was less skilled at it than I was. And then I had to call him on the phone just to get the right report back when, and I was not allowed to use a microscope in the emergency room anymore. So, for us old school people, that was a real kind of step backwards. But anyway, you know what was great though? If we're talking about the old days, and I don't have any old school music like from the 40s to play. Let me find. Alexa, play swing music.
Here's a station for swing music, swing jazz, on Amazon Music.
Let's see. Come on, Alexa. Alexa, next song. This is not going to be worth it. There we go.
Oh.
So, back in my training, now I totally forgot what I was going to say. After all,
Old school stuff, who knows?
Oh, yeah, we used to calculate our own aminoglycoside dosing. And we used to use this thing called a cerubigram. The guy that developed, so for the people who don't know out there, there's a class of drugs called aminoglycosides, and there were tobramycin and gentamicin are the two most well-known. And they're great for sterilizing a urinary tract and some other stuff like that, and using with other drugs. The problem that they had was that they would kill people's kidneys and their inner ears, and so they would have kidney failure, and they'd be dizzy or go deaf. Yeah, and they'd go deaf as well. So they'd be dizzy, deaf, and be on dialysis,
like lady diagnosis.
There you go. So they would. So they did a lot of research to try to figure out a way, how can we dose this stuff? And this guy, Felix Cerubi, actually from Chapel Hill, figured out a nomogram for correlating creatinine clearance with aminoglycoside dose. So, in other words, how well your kidneys could filter something out. That's how you would dose this stuff. So if your kidneys were worse at filtering things out, you would give them less. You might give one dose every 24 hours. And so we would calculate these things with these cerubigrams. And then that guy actually went to East Tennessee State University, believe it or not. If they gave out Nobel Prizes for saving people's renal function, he would have gotten one, but they don't do that. And he ended up somehow at East Tennessee State University. It was a little place in Upper East Tennessee, and that's where he finished out his career. Well, anyway, I remember the first time that I was told I couldn't dose my own aminoglycoside. I was really proud of this thing, and I've never hurt anybody's kidneys. And the pharmacist said, "Oh no, we do that." And then it turned out they were using the same formulas. They were using the exact same thing. They were using cerubigrams too, but they had to do it now because they didn't trust us to do it. And I guess a lot of doctors who didn't go to Chapel Hill didn't get thrown, Cerubi's nomograms down their throat. But now it's like the greatest thing in the world. You just write pharmacy to dose gentamicin. So I'm used to it. It's a lot
easier.
It's so much easier. And then now if they F it up, it's on them. So, yeah. So anyway. All right, enough of the old days. Alexa, stop. Let's take another call.
Hi, Dr. Steve. Hi, Dr. Scott. Lady Di. Well, I'm wondering how long sperm can live when wiped up with a towel. It can live for like 5 days when you pump it inside your lady, but what about when you like... What about if you, jerk off into, a paper towel, and then you toss it in the trash can?
Okay, somebody's gotten a paternity suit.
Oh.
Well, that's got to be what it is. I mean, why else would you care? He's worried that someone's going to pick that jizz rag out and then, somehow shove it into their vagina and get pregnant, and he's got no control over it. Number one, how about flushing it? Don't throw it down the trash. I mean, if it's tissues, as so many people use, Socks. If you're really worried about it, and if it's a sock, throw it in the washing machine. The sperm can live up to 5 days in the uterus, swimming around looking for an egg to fertilize. And outside the body, it just depends. Now, people have tried to claim that they got pregnant in a hot tub. Not possible. Sperm would die almost immediately because of the temperature and the chlorine and exposure to just plain water. Now, in saline, they can last for quite a while. And in a sperm collection cup, they can last for quite a while because I did a motility study, and when my wife was trying to get pregnant, because you got to first figure out if it's the dude, right? If I was shooting blanks, there wouldn't be any point putting her through a big, long workup. And so I took a cup into the bathroom at the hospital, and I masturbated to completion and then took this cup in. And they probably, it was about an hour before they looked at it, and there was still motile sperm in there because it was still liquid. They hadn't dried out. But in a towel, and it dries out, it's minutes. You're talking minutes.
I agree.
There you go. Thank you.
I think that's correct, Dr. Steve.
Although, which restroom was that? Because I don't want to use that one.
Yeah, it was the one next to the doctor's lounge.
Oh, thanks.
And that one that
you just went in the bathroom and did it?
Well, where else am I going to go?
Don't they have stalls?
No.
Okay.
Not at the lab at the hospital. Yeah, here's your masturbation stall. Here's the masturbatorium. No, you just got to go in the bathroom. I found out later that the lock on that bathroom doesn't work because I was sitting in there, defecating one day, and I know I locked it, and somebody hit the handle to come in, and it just popped the lock open, and they just, walked in. They're like, "Oh, excuse me." Can you imagine if that had happened while I was trying to get this sperm sample?
We would all have heard of it.
How would I explain that? Well, I would have to explain it as I was doing a sperm sample, and here's my collection thing. But yeah, everybody would have heard of that. Mm-hmm. Thankfully, my other story, you probably haven't heard this one. It's a good in-the-hospital bathroom story. So I came back from a trip out of the country, or out of the 48, the continental 48, and came back with a raging case of Turista, and we were worried that it might have been Giardia because I did get exposed to fresh water while I was there. So they wanted a stool sample. So I go into the bathroom on the floor, and I'm sitting there, and I'm got this little cup, and you just kind of got to position it just right and make sure that you don't overfill it, because then it's just a mess. And I just got just enough in there, and I, like an idiot, always put the lid on everything right after when you're done with it. But I set it up on the side of the sink, which is porcelain and slippery, and I'm going to pull up my pants after sort of cleaning myself up. And you know how when your pants are down below your knees, it's sort of like a bowl, right? And as I'm pulling my pants up, no clue how this happened, that thing just slipped off of the sink and dumped right into my pants. So into the bowl, right? And what can you do about it? You sop it up the best you can with tissues and stuff, and scrape it up, but you can't get all of it. And now when I pull up my pants, it's cold.
And you can't leave without your pants on.
Is that why they called it street?
It's cold and liquidy, and I'm pulling up my pants, and I've just got this huge shit stain on the back of my pants. And back then, I carried a clipboard. So I walked down the hall, just sort of real tiny little steps, holding my clipboard over my rear end, and had to take towels and put it down in my car so I could go home and take a shower and change clothes. And I just threw those pants away. I just threw them away. I guess in retrospect, I was so mad. But in retrospect, and I was late for rounds and the whole thing, But in retrospect, I could have thrown those pants in the washing machine and washed them and then take them to the dry cleaners. But I just said, I never want to see these pants again, and I threw them away.
So bad.
So, anyway. All right. We have about 2 minutes left. Let me see if I can answer one of these really quick. Well, hello.
I got no stories.
Hey, Dr. Steve, this is Jason in Texas. Got a question about a bladder infection. Had one a while back, and it was so severe that I couldn't urinate for, like almost 14 hours, and ended up going to the emergency room and getting a catheter. And then after that, they put me on antibiotics, and it cleared up. I'm starting to have those symptoms again. Any thoughts on where the...
Yeah, we're running out of time. That's not a normal urinary tract infection when you can't urinate to the point where you need a catheter. That's usually a sign of a prostate infection, and where the prostate is enlarged to the point where it's just cutting off flow from the bladder. So he needs to see a urologist. The other thing that could do this, though, there's two things that can cause you an inability to pee, and one is a urethral stricture, and the other one is an enlarged prostate. I guess a neurogenic bladder or something like that, but that's not what we're really talking about here. He had a bladder outflow obstruction. So he needs to see a urologist, get that checked. There's something going on with his prostate, or he has a stricture in the urethra. If I was a betting person, it would be the prostate.
Me too. I'd bet on the prostate.
Yeah. So a urologist is going to be in the best position to treat that, in my opinion. Thanks always go to Lady Diagnosis and Dr. X. Listen to our SiriusXM show on the Faction Talk channel, SiriusXM channel 103, Saturdays at 8 p.m. Eastern, Sunday at 5 p.m. Eastern, on demand, and other times at Don Wickland's pleasure. Many thanks to our listeners. And go to our website at drsteve.com for schedules and podcasts and other crap. Until next time, check your stupid nuts for lumps, quit smoking, get off your asses, and get some exercise. We'll see you in 1 week for the next edition of Weird Medicine.